Okay, let's start first. I'm sure you're familiar already with this, with the classification of diabetes. So question, um, what is the type of diabetes that is due to insulin resistance? Can you log in? Key in your answers. Change the setting na hindi ninyo makita ang answer. Wait lang. Obviously, majority of us, kita good ay tanan, no? Answered, type 2, diabetes mellitus. So type 1, as you know, is an autoimmune disease that is directed to the beta cells of your pancreas, no? Leading to its destruction. Therefore, the main pathophysiology would be a decrease in insulin production. No? In contrast to your type 2 DM, wherein the main pathophysiology would be insulin resistance. And then eventually it can lead to decrease in insulin production. Other types are, of course, your GDM or your gestational diabetes mellitus, mostly diagnosed in the second or third trimester of the pregnancy. And lastly, you have your other causes of secondary diabetes, such as monogenic diabetes syndromes, diseases of the exocrine pancreas, and drugs or chemical-induced diabetes. Okay? You will have a separate lecture that will discuss the pathophysiology of diabetes. So, for this morning, it will be more about the management. Okay? You also have your LADA. LADA is your latent autoimmune diabetes in adulthood. This is still under classified under type 1 DM, but some call it type 1.5 diabetes. No, the key difference is that in contrast to your type 1 DM, most patients are diagnosed during adulthood, no, at more than 30 years of age. The similarity is that in contrast to type 2 DM, patients with LADA have the presence of diabetes-associated autoantibodies, no? And when do we suspect, no? If your patient, no, is initially, because as you know, type 1 DM is in terms of management, from the onset of diagnosis, insulin requiring na yun na sila. No? Again, the pathophysiology is decrease in insulin production. Therefore, the initial management would be to prescribe insulin. No? However, for patients with LADA, no, initially they are started on oral hypoglycemic agents or OHAs, no, oral drugs, for at least 6 months, no, and then eventually their sugars will be uncontrolled. No? Type 1 DM patients have really elevated blood sugars requiring larger insulin doses compared to patients with type 2. Therefore, if you have a high index of suspicion, you can request for autoantibodies, and if there will be the presence of such, then you can classify this patient as LADA. Now, let's try to answer now. Type 1 DM is classified into different stages. So, do you know the stage of type 1 DM where clinical symptoms are present? So, key in your answer, stage 1, 2, 3, or 4. Okay, Gatanan. Sige, let's try to see your answers. And then, let's look at the correct answer. Okay, good. Kaya nag-advance reading naman, no? So, there are actually only 3 stages of type 1 DM. So, I'd like you to take note of the similarities and difference. All of them, obviously, since type 1 DM, have the presence of autoantibodies. The difference would be in the sugar levels and the symptoms of the patient. No? For stage 1, there will be no asymptomatic patient with normal laboratory tests. However, in stage 2, still asymptomatic. However, your blood sugar or your laboratory results will be in the pre-diabetes range. Okay? And for stage 3, your patient is already symptomatic, and then the diagnostic criteria set will be fulfilled in your laboratory test. Okay? So, speaking of, okay, wait lang. So, again, in terms of classification, to discriminate, especially in the actual setting, autoantibodies is only available in research centers in the Philippines, such as PGH. Unfortunately, we can't request for that left and right here. No. So, when can you suspect that this is type 1 more than type 2 DM? So, these are the following features useful in the clinical discrimination of type 1 DM compared to your type 2. So, patients with type 1 DM compared to your type 2 are oftentimes diagnosed younger with a lower BMI, presenting with unintentional weight loss, ketoacidosis, and hyperglycemia at the level of more than 360 milligrams per dm. So again, speaking of laboratory tests, DM is diagnosed with a result of A, FBS 125, B, RBS 220 asymptomatic, C, HbA1c 6.3, D, 2-hour postprandial glucose of 200 milligrams per dm. Key in your answers. See? Okay, and then let's look at the correct result. Okay. So, The criteria for the diagnosis are as follows, no? An A1C of 6.5% and above, an FBS of 126 and above. This one, a 2R 75 gram OGTT of 200 milligrams per DL and above, or an RBS of 200 and above in a patient with the 3Ps, no? Polyuria, polydipsia, polyphagia, and weight loss or already in a hyperglycemic crisis. Okay, meaning DKA or HHS. Okay, so this is the diagnostic criteria for diabetes mellitus. Okay, what do you mean by fasting? Fasting is defined as no caloric intake for at least 8 hours. And a 75 gram OGTT should be started with an adequate carbohydrate intake of at least 150 grams per day, 3 days prior to the OGTT test as a screen for diabetes. Okay, take note lang, no? If you're gonna use the A1C as your diagnostic test for diabetes, you have to ensure that the laboratory facility that you got that test is certified by the NGSP, no? Ang ilahang machine. Okay? It should be certified. So, majority po of the labs are already NGSP certified. And again, if you're gonna use the A1C as a diagnostic criteria, as your diagnostic test for criteria, you have to ensure also that these are not present, because as you know, your A1C is pila gani siya? It's a 120 days siya, 3 months sugar control because of the rationale is the RBC lifespan of 120 days. That is why if your patient has hemoglobinopathies or is pregnant, pregnant patients has a high RBC turnover, G6PD deficiency, patients with HIV, those on hemodialysis, CKD patients, as you know, your patients with CKD have low erythropoietin levels, or your patient is anemic in general. Do not use your A1C as a test to diagnose diabetes. Okay? So this is a table that differentiates the use of glucose testing and A1C in terms of interpretation and requesting for them. So as you can see here, FBS good is the one that is widely used, especially in our area because of course it's readily available and cheaper compared to your A1C. Pila naman ang FBS karon? It ranges from 100 pesos to 200, 300 in some laboratories. Compared to your A1C, sa may pila man ang cheapest na A1C? 1,100. Oh, I know of a lab na more 650, 700, So that is why we often opt to request for FBS, and then the difference is, take note, the time frame we mentioned already, chronic, and this is acute. Munang some patients, like I don't request, if for follow-up already, I started the medication, I don't request for the FBS after 3 months, just the A1C. Because some patients mag-cheat, days prior to the follow-up, Ala, mag-diet yun na sila. Follow din sila, no? Wow, 85 ang show FBS. Pero ang A1C, 10.5, no? So, you know, the discrepancy there. So, yung dili yun ka-cheat ang inyong patient, no? And then, of course, pre-analytic stability, good for A1C, for using the FBS, if you're using serum or plasma, it should be separated immediately. No, this is for the red text. And then, FBS mostly on serum, plasma. This one is ETA or whole blood. Okay, assay standardization. That is why we're using NGSP certified because the A1C has been well standardized. A1C is non-fasting sample. Fasting is for FBS. Take note lang that acute factors can affect the level of your FBS compared to that of your A1C. That is why, for example, the patient is admitted, no, due to, let's say for pneumonia, then you request for an FBS, and then the FBS is 128 milligrams per dl, no, above the cutoff which is 126. You have to be conscious of diagnosing your patient already as DM because patient has an infection and acute stress, so you can repeat, no, or confirm or request for an A1C to confirm the diagnosis of DM, no? Then, for the, we mentioned this already, and then test interference. Okay. So, we will not be satisfied in terms of confirming the diagnosis, no, unless the patient is symptomatic, no, and then you have a very high index of suspicion, going back to what I mentioned, no? Or let's say a patient comes in just for an annual physical examination, no? Requested by the company, nagpa-executive lang po do. And then patient is asymptomatic, came in with a result of FBS 128 milligrams per dl. Do you diagnose the patient immediately as having type 2 DM? No. You need to repeat and confirm the test, either with the same sample or you in two separate test samples. So you can either request for an A1C, no, or you can have the patient have a repeat FBS the next day, okay, or within 2 weeks. Pwede na po. Now, what about let's proceed to screening, no? Do we screen patients with type 1 and type 2 DM? Now, for type 1 DM, no, since we mentioned it is an autoimmune disease, we only screen, no, in patients with very high index of suspicion, no, especially in terms of genetics or family history. So we do it by screening for the following autoantibodies, no, GAD, your IA2, ZND8, no, and having multiple confirmed IgA autoantibodies is a risk factor for clinical diabetes. Now, what about type 2 DM? Question here. At what age should screening for DM be done? For Filipinos, A, 25, B, 30, C, 35, D, 40. So meaning, even if asymptomatic ka, no, the mere fact that you're a Filipino, or at what age do we start screening? Or the mere fact that, let's see. No, this is 35. This is 35, dili na 40. This is 35 years old. Testing should begin at the age of 35 years old. However, if you have the following, then you test earlier pa yun, no? So what are these features? If the individual is overweight or obese, no, and has one or more of the following factors, then you screen earlier, no? So who are these patients? No? High risk, kita, Filipino, first degree relative. When you say first degree, mama, papa, igsuon. Anak, pwede first degree, no? Pero, first cousin, grandma, no, that's not first degree. History of cardiovascular disease, hypertension, HDL, and or a triglyceride level, PCOS, physical inactivity, and other clinical conditions associated with insulin resistance. Okay? And then, take note, if the patient, here, number 2, if the patient has pre-diabetes, then screening should be done annually. Okay, so nakuha mo karon ang inyong FBS kay 117, then have a repeat test next year for screening. And then, for patients diagnosed with GDM, no, the screening should be done every 3 years. This is what we mentioned, no? And then, let's say nagpa-screen ka, normal, 95, no? Okay na ba? Happy na ko? Pwede na, dili na magpa-repeat. Now, if the results are normal, testing should be repeated at a minimum of 3 years interval, no? With consideration of more frequent testing depending on the initial result. Again, no? If normal, repeat after 3 years. If pre-diabetes, repeat annually. Okay? Test at 35 for all, but younger if you have the following. Okay, you got that? Sige. Now, in patients with HIV, exposure to high-risk meds and history of pancreatitis, no? When you say high-risk meds, what are these medications? No? Of course, as you know, steroids, no? Those on statins, those taking thiazide diuretics, antiretroviral drugs, and second-generation antipsychotic medications are advised or recommended to have their screening also for DM. Now, in patients with HIV, no, they should be screened, number 1, before starting their antiretroviral drugs. If they will be switched to another antiretroviral drug, or 3 to 6 months after starting or 3 to 6 months rather after starting or switching to another antiretroviral drug. If the results are normal, repeat annually. And then for what about those with history of pancreatitis, no? It should be screened within 3 to 6 months following an episode of acute PANC, and those with chronic PANC, then screening should be done annually. Okay? You also have mga diabetes risk assessment forms that you can download, no, by the ADA to determine the risk of having DM. So we mentioned also we have to mention also the pre-DM na range, no? For IFG, it's 100 to 125. Impaired glucose tolerance is 140 to 199, and A1C of 5.7 to 6.4. So take note of the terms, ha? IFG is using the FPG or FBS, and IGT is using the 2-hour Prandtl 75 gram OGTT. Okay? Now let's proceed to the management. Okay. The management should be a person-centered collaborative care. No? It should be culturally sensitive. No, let's say for example our Muslim brothers and sisters. If we're talking about diet, no, especially during the time of Ramadan, no, you also have to like their medications in terms of side effect. When do you need to adjust? When they are at risk of hypoglycemia, no, if you're giving insulin during your time of fasting. So it has to be culturally sensitive, no, and strength-based language with active listening. Okay? And as much as possible, it should be through a coordinated, multidisciplinary team. No? You have, if your facility is capable, you have your diabetes educators, clinical nutritionists, of course, us doctors, no, nurses. If you can refer the patient to physical therapist if warranted, or health coach, a fitness coach, no? Of course, in collaboration also with the pharmacists, dentists, podiatrists, or your orthopedics, and then mental health professionals, very important. So this is basically the person-centered collaborative care. No? With basically the goals of care is to prevent complications and optimize quality of life. Now let's say for example we already have a patient with confirmed diabetes mellitus. What should be done during the initial evaluation of these patients? Of course, we have to review the past medical and family history. Okay. And then, okay, autoimmune disorder, especially if you're considering type 1 DM. And then, of course, take note. By the way, ang kanang 3 columns there, this is initial visit, when do you assess? And then every follow-up visit and annually. So you have, of course, obviously, during the initial visit, you have to ask everything, no? But on follow-up, usually after 3 to 6 months, ask again, no? If are there any episodes of hypoglycemia? And then, are there any history like blurred vision, no? Any traumas related, or what about food assessment? You have to take note every after follow-up. And then this is done annually. This is done annually. Now for the behavioral factors, take note also of the eating pattern, weight history, and very important, assess familiarity with carbohydrate counting, and then physical activities, screen for OSA as well, no? Tobacco, alcohol, and substance use. And of course, you have to review every follow-up, no? The medications, the reaction to their medications, are there any side effects, no? Are they compliant to their medications? Are they taking mga alternative medicines, no? And then, review your vaccination history at least annually. So in terms of vaccination, these are the recommended immunizations for adults with diabetes. Of course, your COVID-19, your Hep B vaccine, your flu vaccine annually, your pneumonia vaccine, your HCV, your shingles, Shingrix, your RSV, and your Tdap. No? So these are the recommended vaccinations for patients with DM. And then for, in terms of technology use, most of your patients should have their glucometers with them, no? Assess, no? If they are still using, what about their monitoring results? Are they properly using their devices, no? For those on insulin pens, insulin syringes, on insulin pumps, you have to review as well, no? If they are using their devices properly. Then of course, your social support, very important as well. It should be holistic. The care should be holistic. No? And then, for the physical examination, no? Of course, take note, no? You have to do your fundoscopic examination or refer the patient to an ophthalmologist if you don't have the apparatus, no? To screen for diabetic retinopathies, cataracts, glaucomas. These are the diabetic eye diseases. Palpate for the thyroid, check for the skin, no? Are there any diabetic ulcers, diabetic foot, signs of PAD or DVT or CBI, no? Do a comprehensive foot examination and screen also for the mental health as well. So all this, especially for the foot examination, we will discuss during the next lecture, no? As we discuss the complications of diabetes. Now, after doing your history and PE, can you type down what additional laboratory tests should you request aside from requesting for the FBS, HbA1c? Can you type in your answers? What additional tests would you like to request? Your priority, ha? Let's see. UA, Korea, liver function test. Okay. So did we miss? Ako may na-miss? Okay, let's see, ha? Okay. Now, during the initial visit, and at least annually, you request for the following. So correct, we requested for a lipid profile, the NFTs, is spot UACR, no? Or a serum urea and compute for the EGFR. Okay? TSH, if you are suspecting type 1 DM, autoimmune man siya, no? So in type 2 DM, obviously you don't request for TSH, no? If your patient is on metformin because metformin is associated with vitamin B12 deficiency, then you can request for a vitamin B12 assay. However, what we often do, since again, really available ang vitamin B12 assay, if your patient is on metformin, you can prescribe already a vitamin B complex, no, with your medication, with metformin. CBC, serum potassium, if your patient, no, is on ACE inhibitor or ARB. As you know, these are the first line antihypertensive drugs for DM patients, no? And then, if your patient has high risk for osteoporosis, no, you can also request for calcium, vitamin D, and phosphorus. Now, in terms of management, how do we these are the different treatment strategies. First, we need to assess the risk of diabetes complications. Then we do goal setting, and then eventually our treatment plan. Now, in determining the risk of diabetes, we have to, number one, establish the ASCVD risk factor, or do the 10-year ASCVD risk assessment, and then check for CKD. If it's present, then stage it. The risk for hypoglycemia, assess for retinopathy, neuropathy, and assess for NAFLD or NASH. Okay. This will again be discussed in detail during the next lecture as we discuss the different complications of diabetes. But I'd just like to highlight, there's an app that computes for your ASCVD risk that you can just input and determine the risk of your patient. So when you say ASCVD, risk for stroke, TIA, risk for MI, heart failure, and CV death, and PAD, acute limb ischemia, risk for major amputation, limb revascularization, and symptoms progression. So if your patient has claudication, so on and so forth. Now, for hypoglycemia, we have to assess for the risk of hypoglycemia. So, the history of hypoglycemia should be reviewed at every clinical encounter for all individuals at risk for hypoglycemia and evaluated as indicated. Who are these patients who are at high risk? The major risk factors are the following. Those with recent level 2 or level 3 hypoglycemia. What do we mean by level 2 or level 3 hypoglycemia? If your patient had an episode of a glucose test of less than, a CBG test of less than 54 or level 3, meaning a severe event characterized already by altered mental and physical status requiring assistance for treatment of hypoglycemia irrespective of the glucose level. What na nakamata? What na nakamata kay nag-hypoglycemia na, and then after nadala sa ER and then natagaan o D50 when you say D50, that's 50 grams of glucose IV, then that's level 3 hypoglycemia. Or for, let's say, for example, nasa balay, giduka, dok, more nagkatulog-tulog na yun siya, gipukaw siya, dok, dahil pag-inom sa iya o kanang coke, kay nabaskog na dayon, So that's level 3 hypoglycemia, But take note, it should be diabetic also, kasi amo lang na nag-level 3 hypoglycemia na ko. You also have to have other risk factors, Who are, aside from having level 2 or level 3, intensive insulin therapy. Meaning to say, let's say, some patients will have siya basal insulin and then prandial insulin. So you say basal, mag-inject siya and that insulin will cover 24 hours. So, siya basal. And then, the patient will also have prandial. Every meal, before meal, mag-inject pa din siya to cover for each meal, depending on the level of sugar. So, 4 times a day, the-inject ang patient. Okay? So, these are patients on intensive insulin therapy. Or let's say, for example, twice a day, they-inject. I have one patient, 40 units in the morning and 30 units in the evening. 70 units a day ang kataasin ng insulin. So that's intensive insulin therapy. Impaired hypoglycemia awareness. So patients already on recurrent episodes of hypoglycemia and on very high insulin doses will develop eventually impaired hypoglycemia awareness. Wala sila kabalo na hypoglycemia na dahil sila. End-stage kidney disease. Patients with CKD, due to the reduced clearance of the insulin from their circulation, tend to have there will be stacking of insulin in the circulation. So these patients are at risk to develop hypoglycemia. And of course, your patients with cognitive impairment or dementia. For the other risk factors, food insecurity, no, di na mukaon, low income status, homelessness, no, those on fasting for religious or cultural reasons, no, as what I mentioned earlier during Ramadan. So these patients are at high risk for hypoglycemia. And what about the drugs, no? Again, there will be a separate lecture on the pharma drugs in DM, but take note of the drugs associated with hypoglycemia. Insulin, no? Your sulfonylureas, your SUs, or your meglitinides, no? So these are the drugs that are at high risk for hypoglycemia. Other risk factors are as follows. Okay, level 1, glucose should be less than 70 and more than 54. Level 2, glucose less than 54. Level 3, as what we mentioned. Now, how do we treat hypoglycemia? I don't know if included, but the use of CGM. Now, what is CGM? Continuous glucose monitoring is more beneficial and recommended for individuals at high risk for hypoglycemia. As to why, I will explain on the later slides, no? And all individuals taking insulin or at risk for hypoglycemia should receive structured education for hypoglycemia prevention and treatment with ongoing education for those who experience hypoglycemic events. I always tell my patients na mas delikado pa ang hypoglycemia kaysa sa taas inyong blood sugar. No, you're depriving your brain of glucose. No, I had, just to personal experience, I had a patient who is from Camiguin, no? Sabi ka na Camiguin dire? You have anyone from Camiguin? Na? Ako lang, I'm from Camiguin na. Taga-asa ka, oy. Taga-asa ka sa Camiguin. Okay, Mambahaw? Sagay, okay. Taga-Mambahaw ko. Anyways, I had a patient from Camiguin. You know, ang biyahe from Camiguin, ang lansya, ang first trip, di ba, 4 a.m.? 4 a.m. Nabay 2? Somewhere 4 a.m. ang first lansya going to Balingwan. Now, this patient nag-inject siya before dinner, no, sa iyang insulin, nag-inject siya. And then, first trip siya. So, nihaw siya sa iyang balay 2 a.m. Kaya layo pa man ang katong Mambahaw to, then magsakay lang siya van going to the pier. And then, 4 a.m. dapat muhawa ng ang ferry o ang lansya. Na-delay ang lansya. So, wala po siya nagkaundaan before leaving their house. So, na-delay ang lansya. Wala po siya anything to munch on. Like, bisa candy or sugar, no? Na-delay. Naabot siya sa Gaisano mga around 10 a.m. na without any breakfast, no? And then, 6 p.m. or earlier ang iyang last injection. The patient had diaphoresis, sa Gaisano, had diaphoresis, no, had an MI sa Gaisano pag-abot. No, so that is just to establish, no, how risky it is, no, and to have hypoglycemia. Ato lang, that's a personal experience with of mine. And patients, kung mag-hypogly, dili na lang mutuunin mo sunod. Okay, yun sa man to akong gibati, yun sa man itong i-inject ni Doc sa kuha. If you don't instruct your patient on the proper timing of their insulin and then the timing of their meals, no, mahadlok na. Have you, come on, naka-hypogly ng rid mo. No, hindi na mo, sige na magtuon. No, hindi na mo magkaon. Or, I don't know, if inana mo, ako stress eater man ko. No? If, I don't know, sa amin, hindi na grabe na tuon, hindi na makaon. No? You know how it feels. No? After sa exam, ay hapanin mo ma-feel. After sa mga inyong sympathetic na human na exam, Kaya panggutom. No? You know the feeling of hypoglycemia. No, it's very uncomfortable yun, no? Nasa, tuk, dili na ko mo-inject anak, di na ko mo-inject anak, kung saan na yung mga ano, no? So, then SUs also very, your sulfonylureas, no? Especially if your patient is in the older generation, like glimepiride, no? Glibenclamide, these drugs that you have to take prior to a meal, no? Because it's an insulin secretagogue. It tells your pancreas to secrete or produce insulin, so you have to take it at least 30 minutes before a meal. Some patients, no, malimot o kaon within 30 minutes, mag-hypoglycemia, no? I had one patient na nanghilamon pag yun, nanghilamon, niinom siya sa yung tambal, nanghilamon, at to sa layo. Wala na siya kabantay nga nalipong na yun siya dito kay wala naman siya namahaw kay nanghila mo na, no? So kana, so you have to instruct your patients really. Now, when do we refer for initial care management, no? To an ophthalmologist or an eye care professional for at least annually for a dilated eye exam. No, for those with to your OB/GYN, no, for family planning. If you have a diabetic patient, no, who wants to get pregnant, for your nutritionist, dietitian for MNTs, you know, DMSE for education and support for your dentist, no, if indicated to the following professionals as well. Okay? So after we assess for the risk, then we set our goals. Okay? So if you're, of course, for your glycemic control, we set our A1C and blood glucose targets. If your patient is hypertensive, we set our BP targets and your diabetes self-management goals. So in terms of A1C, it should be requested at least every 3 to 6 months, twice a year if the patient is stable, no? And then FBS, postprandial sugar, every 2 to 4 weeks, and CBG if your sugar is controlled at least twice a week to estimate the trends, no? And then as much as possible, glycemic target should be achieved within 6 months of diabetes, of diagnosis or first prescription. So in terms of the A1C and their corresponding blood glucose levels, just take note of table 6.1. Now, why is A1C monitoring very important? No? According to the UKPDS study, for every decrease, 1% decrease in your A1C, there will be a corresponding reduction in the micro and macrovascular complication of diabetes. So speaking of A1C, in most adults, what is the HbA1c target? Key in your answer. 6.5, less than 6.5, less than 7, less than 7.5, less than 8. Okay, key in your answers. Okay. Correct answer is less than 7%. Okay? In most adults, the A1C target is less than 7%. However, no, HbA1c target in terms of discussing with your patient, your HbA1c target, you have to individualize it. No? Again, the question was in most adults. Now, you have to be less stringent, no, in patients with long diabetes duration, high hypoglycemia risk, high treatment risk and burdens, pharmacotherapy without non-glycemic benefits, established cardiovascular complication, and severe life-limiting comorbidities. Let's say, for example, no, you already have a bedridden patient, post-stroke, na nagdiha, no, 6.5, hindi pa ang target, ani ni nanay, sus, pakanaan na lang taon lang siya. Okay, no, the quality of life is more important. Their hypoglycemic risk, no, is very high for these types of patients, no? So, no A1C goal already. If you have an older adult with complex or intermediate health, for example, you have an 80-year-old nanay, post-MI already, eGFR of 30, hypertensive pag yun, no? Nana lang sa balay, no? Yung 8% na lang ang A1C. Dili pagbalik 6.5, pagbalik sa ni nanay kay 7.8%, agoy nay, mag-insulin na yun ka nay. Okay, taas gihapon, nakaduhan ako katablitas para sa imong sugar. Taas gihapon, 7.8, mag-insulin na yun ka. You do not intensify. Ha? You are okay already with an A1C of 7.8%. Okay? For healthy older adults, 7 to 7.5%. But if your patient, no, is newly diagnosed with low hypoglycemic risk, with low treatment risk and burdens, pharmacotherapy with cardiovascular kidney weight or other benefits, and no cardiovascular complications, few or minor comorbidities, then you can be more stringent. No? Let's say you have a 42-year-old obese patient, call center agent, non-hypertensive, newly diagnosed with good family support, capability to buy the medications, no? Less than 6.5 will be the goal. No? So again, individualize your targets. Okay? Now, what about monitoring of blood glucose? No? This one. What are the advantages of SMBG or self-monitoring of blood glucose? This reflects the glycemia directly, effective in optimizing nutrition and pharmacologic therapy. Okay? Now, in terms of SMBG, we mentioned ganina twice a week, right? If stable. No? When you say stable, or only on oral hypoglycemic agents, A1C is controlled, monitoring is controlled, then at least twice a week. However, no, if the patient is on intensive